Hi everyone, welcome to the Women's Networking Zone and welcome to the daily dialogue session. We're going to go around and introduce ourselves and then we will launch into what we have to say.
Hi, I'm Daisy David from India. I'm representing ICW Asia Pacific region.
Good morning, everyone. I'm Elsa Chia from Philippines, representing Ed Society of the Philippines.
I'm Lorangelis Thomas Negron from Puerto Rico. I'm part of the Positive Youth Network from Latin America and Hispanic Caribbean.
Welcome ladies. I'm Rebecca Matheson. I'm a local Melbourne woman living with HIV and I'm going to talk about the Australian perspective of our sexual and reproductive health rights in Australia. I might pass over to my colleague here and she can start with her lived experience and her story about sexual and reproductive health rights.
Hi everyone. I'm 26 years old. I've been living with HIV for 26 years old. I was born with HIV. So I also work with two organizations on prevention, on HIV, on women's, um, and working there and with my own experience. Um, One of the issues that actually worries me about sexual and reproductive health is about sexual education, not only because at the school we don't have any kind of sexual education. They only talk about abstinence, so obviously they don't know how to protect themselves. But also at the clinics, we don't get that education neither. So when I was 18 years old, I got infected with chlamydia. I was so scared because I didn't know that it can be cured or anything. So it was very complicated. Not only having HIV, but also having chlamydia. And the worst of all was the man who gave me the result. Um, he also sexually assaulted me. Um, so sometimes, working in prevention, I not only worry about those women who test positive at the clinics, but also what kind of information we are giving them to take care of their sexuality and also enjoy it because we are HIV positive doesn't mean that we won't have sex. We like we like to have sex, but we have to learn like which are the safety way to have it. Um, Also about those women who are pregnant in Puerto Rico, um, a woman when is pregnant, she get the HIV test when she's 3 months, 6 months, and before going in labor. Um, but actually, they don't get informed. They just take the blood and make the test. So they are not. They don't talk. They don't talk with them about the HIV test and if it come out positive, what should they do? They only gave the medication for that baby born without HIV, but after that, it doesn't necessarily stay on treatment. So that's like a big issue that I think is happening. And also, working in prevention, um, the issue that actually now worries me the most is about those women who are migrants. Migrants, how? Immigrants, yeah. Um, because they don't necessarily have um, the healthcare service because discrimination. Most of the women who are immigrants in Puerto Rico comes from Dominican Republic, and actually in Puerto Rico, people like discriminate people from Dominican Republic, and they also get discriminated um, when they go to access services. not only because they are not like citizens of the country, but also by race and everything. So when 6 months ago, I make the HIV test to this woman. She was having the HIV test because she wanted to get married, to have the documentation and everything. But she didn't know that she didn't need the HIV test for that. Um, Her test came positive, um, but actually it took her like all these 6 months um, to engage to the health services, because it was very complicated for her accessing services. So I know that this happening like a lot with different women, not only Dominicans, but every other immigrant women in my country. So that's like a huge issue that I'm dealing now. So that's all.
Uh, I would like to share with you. I'm also living with HIV for this year is coming to 18 years. So most likely the Philippines focusing mostly all the programs, civil society working on MSM. Then women issue had been neglected. So far, even though we lobby for the support from the government or other NGOs, but then since the female issue is like from the registry is very like only 9% from the total HIV registry in the Philippines. Just like the Philippine government don't focus on the female issues. So one of our issue is that we don't have like health facility where to go all the women about accessing reproductive health services. We don't have this pap smear. Then one of our worries that most of the women in Philippines died for cervical cancer. Then most of the worker working in HIV, they don't focus on the data. Why is it, or they don't have the like, they don't have express themselves like focusing in research. Why most of the women died in cervical cancer? So one of the cause of death of women living with HIV in the Philippines is cervical cancer or breast cancer. So we are just very much worried because like female issue is been neglected in our country. Most of the government and the NGOs working on MSM, LGBT and others group. But for women, really no services, including our children. So we feel discriminated also in when we access in the government or public hospital, especially some women is pregnant. So if they go for cesarean, some of the doctor they have to level up the bed. Uh, they put up this is highly contagious. So even to the baby after the pregnant women give birth, also the baby has the label also infectious. So most of the people like asking why is it at the young age or newly born baby has the label of infectious. So we are lobbying for this that with fair access and like treating us normal and like a normal person, but then we cannot get. So our worry is that for all the health facility, we're lobbying for like one hospital and per region that women could go and access the like pap smear and all the tests for the women, but then just like neglecting us. So that's the problem because the cases in Philippines now is highly increasing, almost 25%. But then they found out that like the percentage of women was very less compared to MSM. So even though we keep on lobbying about our issue and we want to put up network for women, that then they say the number is not enough. That's why our issues has been like dying slowly. Nobody listened to us. So we're really very thankful being here. Then our voice has been heard since few women and Philippines all come here. So I'm very proud to be here and share with you our experiences being HIV positive.
Hi, I'm Daisy, and I just want to share in three perspective of SRHR. One, my age is above 45. I am having menopause stage. 2 years I am having continuously bleeding. I went to my doctor, but doctor said that you are go for the scanning. And then I went for scan, and it's a fibroid. It's just 1 centimeter. Now after 6 months, they have given some tablet, but it is continuously bleeding and severe pain. I continued the tablet, and 10 months after I went there, again they asked me to go for the scan. And now they said that to me, go for only option is to do hysterectomy. I was just requesting that, doctor, can you do only removing my fibroid? It's not possible. You have to go for hysterectomy. And then I went with some other doctors, referring with some other hospital doctors, private doctors. And they said that they have given some tablet for to stop my bleeding for 3 months. Why I'm putting this is menopause is also part in SRHR. I'm taking ART, my government office, hospital if I am going. I am an activist of lead activist in India. As a woman living with HIV, if I am going, there is no possibility of properly referring to the people to this gynae department. But WHO, UN, all the policies are there, but everything is in the paper, in the guidelines. The implementing part is not happening in developing countries, so-called India. This is what I just want to share about my thing. And I'm working, though I'm a positive living with 17 years, I'm working as an advocacy officer in World Vision India. And we are working targeted areas in countries. And ICWAP is giving a wonderful module of sexual reproductive health rights. And that module we are taking and implementing in our target area. We plan to cover in our target area each state's 1,000 women, providing service delivery, making them to learn, do advocacy for their updated issues. And then we are providing this capacity building to empower them to understand and aware the information. And because of that training, we got very good outcomes of now women, widows, they want to go for marriage. And they would like to do advocacy to the doctors for their pap smear and cervical smear. Of course, there is policies there and guidelines is there, but when implementing part, referral systems, these all the problems are facing in India. And also, the other thing which I would like to share here is like sexual reproductive health rights, people are thinking for, that is different. Maternity and child health, that is different. And HIV positive women, ART, that is different. Everything is working in different sector. But all things is continuously linking. That comprehensive package is not possible to make any women to aware about the informations, to get counseling, to go to ARV, and then to refer to PPTCT. So PMTCT, SRHR, maternity and child health, everything is working in different way. Comprehensively, if it is happening, definitely women living with HIV, general population women, they can have more information. With this I end, and I just look for your comments after finishing this. Thank you. Questions?
I think we have a question here from...
Hello. Yeah, I am basically a medical doctor from India. So I just want to add a few things what our colleague friend has just now spoken about. I'm basically an obstetrician and I'm practicing dermatology after finishing my obstetrics. So I worked in AIDS Control Society, AP AIDS Control Society, AP SACS, AP State AIDS Control Society as a deputy director. In the department of PMTCT, that is Prevention of Mother-to-Child Transmission and Early Infant Diagnosis. So, as our friend suggested right now, that comprehensive healthcare is now available. It's now available, and it's only under one roof. Everything is under one roof, even the STD treatment and the HIV, one prick, two tests, as well as the comprehensive medical, maternal and child health care. That's one thing. And the second thing, if you ask me, my suggestion as an obstetrician, what I can suggest you is, because you are in a perimenopausal stage, that is called perimenopausal because she is around 40, 45. So these fibroids, that too, the size of the fibroid is only 1 centimeter. So the fibroids during the perimenopausal years, because they are estrogen dependent, need not be removed. Once the menopause is attained, the fibroids will regress automatically. They regress automatically. It doesn't need any hysterectomy. So doctors, they do business now. This is not the healthcare delivery. It's morely of most of things are now taken in a commercial aspect, and so probably your doctor might have suggested you to go for hysterectomy for financial reasons, just to gain money out of you. But frankly speaking, as an obstetrician, you can refer the books also. No fibroid need to be taken from any woman from the uterus when she is in perimenopausal age group. They regress automatically. And particularly a fibroid of size 1 centimeter need not be removed at all, unless until it's more than 5 centimeters and it's giving you some problem. Now that you had menorrhagia, that means excessive menstrual flow, so probably they might have suggested because of that, but not because of the size. That size will never cause menorrhagia also. Menorrhagia is a part and parcel of perimenopausal symptom. Some people will have more flow and some less, irregular cycles, this, that, and all. That's a part of the game. That's it. You don't have to attend any clinic for that matter for the fibroid concern. Thank you.
Thank you. Before I go on to tell you a bit about my lived experience, I think that really highlights, though, for women living with HIV around the world, the kind of extreme interventions that we see around our sexual and reproductive health and our bodies. And often women aren't given choices or given extra information about what we might have access to. And I think that really highlights that in your example. So thank you. Thank you very much. That was terrific. I've been living with HIV for 20 years. I was one of the first women in Australia to find out I was pregnant and know my status and have access to antiretrovirals. It was in the mid-1990s. So, I've seen huge leaps and changes in our in the way women are treated in the hospital services around sexual and reproductive health. In the 90s, they were really just finding their way. There were some very strict protocols that needed to be followed. And we didn't talk about choices or options back in the 90s. It was very clear cut for women in Australia. This is what you do, this is how you do it, and this will be the outcome for you. Sorry, I've been so excited at this conference. I've talked so much, I've lost my voice. Women in Australia don't have much of a voice, so we have to take every opportunity we have to really speak up about our issues and give it visibility. And back in the 90s, it was really difficult for women like myself who were falling pregnant or considering having children, because there wasn't a lot of information in Australia. We are a minority within a minority. There's only a couple of thousand women living with HIV spread across Australia. So a lot of the information and access to services and service delivery that was available in the 90s and even now is for MSM, so for men who have sex with men. In some of the larger areas of Australia, like Melbourne and Sydney, we have service delivery for women that is, world leading. It's streamlined. It's amazing. But we still, 20 years down the track, we're still having limited voice. We're not consulted through policy makers. The people that represent us at the most highest levels in Australia around reproductive service frameworks are either people not living with HIV or gay men. So I think for us in Australia, when we talk about sexual and reproductive health rights, we need to talk about having a systematic way for women to feed into the policies that impact mostly on our, greatly on our lives. And I talked to some young women about this last night, and I was saying, you know, I'm getting old, I'm heading towards menopause. We need some young women who are wanting to step up and take up the banner and really talk to policymakers in Australia about, you know, what we need, what we want, and how they can deliver that for us in a meaningful way. And it, you know, like all the women, I think, around the world, this is a challenge in terms of having women step up and take the banner. I would also like to talk a little bit about cervical cancer, because my colleagues have also touched on that. And, you know, globally we are seeing women living with HIV dying from cervical cancer. It's a big issue. It's certainly an issue that the regional ICW chapters and the global chapter of ICW are taking up the banner of cervical cancer and starting to have dialogue at all levels, including women at the grassroots, about how we can support them to access information and access services that will prevent them from dying from cervical cancer. Even in Australia, I mean, we have, you know, amazing services and we have access to pap smears, but still women fall through the cracks. Many GPs don't know that women living with HIV need to have more regular pap smears, and there's not a systematic way that health services here follow up with women who are living with HIV who require pap smears. So I think it's a universal issue that we need to raise up at this conference, raise up as we move forward, and ensure that women have access to information and know what they need to do to look after themselves and prevent cervical cancer. It's just, you know, it's just absolutely insane that we can't get that information out there to women, and that we are still seeing so many women dying from cervical cancer in every region of the world. I'd also like to touch on menopause, because my colleague here raised it, and I also, you know, many women in the Australian epidemic of HIV are ageing, and we're starting to go through menopause, and you know, a lot of the doctors that we see have absolutely no information for us about HIV and menopause, and they're just feeling in the dark, and so are we. And I think it's an area that has been underexplored in Australia, and also not a lot of information globally for women around menopause and HIV and the intersections and the interactions of menopause and HIV. And I think it's an area that needs to be highlighted, and a lot more work done for the ageing, or the maturing, not the ageing, we could say maturing, like a fine wine, the maturing women living with HIV. You know, sexual and reproductive health rights for women living with HIV, it's a complex road to navigate in terms of accessing services. And I think that, you know, we have been having a lot of dialogue at this conference, and we will continue over the week about how we can interlink SRHR services and HIV to ensure that women have a streamlined access point for sexual and reproductive health services that is not separated and divided, and not easily accessible. And not discriminatory. You know, women that we've talked to over the last months around accessing sexual and reproductive health services talk about the discrimination, the lack of denial of services, and the stigma that they've faced in accessing services, and not just the external stigma, but, you know, the impact of that has on us, and how we internalise that stigma, and how we see ourselves and how we live our lives. So I think I'm going to hand back to my colleagues to talk a little bit more about that. But, you know, I'd like people to really think we talk about stigma and discrimination, but I'm not sure that people really get it, because it's not just external. It's just not what's happening out there. It's also what's happening to us internally, and how we feel about being discriminated, and how we think people are judging us, and how we see ourselves. And I think we don't often talk a lot about the internal stigma, because it's hard to articulate. It's hard to define, but it has such a huge impact on how we live our lives, and how we see ourselves, and how we interact with services and people and the world around us. I think that we need to give it a bit more space.
And also, I just want to thank for the personal advice, and it's, as Rebecca said, it's the part of so many factors. The main is stigma, and also it's fear. Women living with HIV, they are facing that fear when they are crossing some problems, maybe menopause or pregnancy or a delivery and whatever it may be, first of all, the fear still is not going. And also, there is some places as per that packages are there, service deliveries are there, but there is lack of information. And women are not that much literacy level they completed. And accessing that information is not a matter for them to easily coming and getting an informations in the hospitals. They are coming. And also this counseling part. It's a vast area which I couldn't able to, everybody knows about that. Center of ARTs, SRHR is different, ART is different not. People living with HIV coming for their ARV, the women living with HIV has to refer properly to this gynae department. If they are just as because of the lack of information and heavy factors of this crowd and more people are coming for day, they couldn't able to get information and they are not able to get the counseling. Some places it's only group meeting. There is no counseling, group meeting. And so the fear and self-stigma, and they cannot able to go and find out what they exactly want to go. Those services are there, they couldn't able to go. As Rebecca said, one part of stigma and fear. And apart from that, services and information and counseling. So everything together, comprehensive package and all that referral systems, and make women should get not only ARV, if she is pregnant, she has to get information up to this maternal and child, and means postnatal, starting from antenatal up to postnatal. This is what I just want to give that.
For us in the Philippines, like stigma and discrimination is very high for women because most of us suffer stigma and discrimination in the health worker or in the health facility. So if we go there, like if we access something like for cesarean or for any services, the doctor will say, we want to resign, I don't want to handle you. So that's why we are lobbying for the Philippine government to have like a centralized facility for women living with HIV alone, because in our country, really we can say that women issue is being neglected for now, because they are really focused on the young MSM, the LGBT issues, not for women. So for us really, when I went to the hospital when my daughter's still alive, then the doctor told us that we have only 3 days to live. After 3 days, we're going to die. So I'm thankful because now is my 18 years, although my daughter already died. So this is the experience I'm going to pass on to the young women, that facing the issue and talking about this to other people is not, I think, is a part of our life, not to being isolated, because most of the women, once they feel discriminated, they just go and hide. They don't want to talk about it. They don't want to access any health facility. So they just prepare to look after the children. They want to go out. They want to join the support group just to isolate themselves. That's all.
Well, I will say that about stigma and discrimination, the worst of all is the discrimination that comes from health providers, as doctors, gynecologists, and social workers. I remember when I was like 15 years old, the doctors used to tell me that I should not have children or kids because they may be born with HIV also, just like me, and that was like almost 10 years ago. But I know that this keeps happening, because I don't think if doctors are aware, because they see us like we are young, but they don't realize that we need some sexual information and education. And also that complicates a lot the access to health, because sometimes when you know that doctors will stigmatize you, you just don't want to go there. And also for those women that have children, it's even harder, because most of them doesn't feel comfortable having their kids around, and I mean, a woman have a lot of things to take care of, and I don't think that health providers realize that. So that can be a little bit more complicated for us women. And obviously, in Puerto Rico, it's happening the same thing. Most of the services are focusing now on men who have sex with men, because they say that the incidence is growing in that population. But is obviously, if you make the HIV test to men who have sex with men and you don't test women, obviously the statistics will say that that is the higher population. That so it doesn't make any sense, and the prevention always go to them. And when I am at some community making the HIV test, women doesn't feel like they need to, because they always say to me that I have husband, I have my partner, so I won't get test. So they don't feel like they need to do it. So actually, I think we need to change the speech. So that would be all.
Thanks. Yeah, I think that's really important around testing. I think one of the other issues that we haven't highlighted that is happening in every region of the world is forced and coerced sterilisation of women living with HIV, and also forced and coerced abortion. And I think my colleague Daisy here would like to talk a little bit about forced and coerced abortion, but certainly sterilisation in several countries across our region in Asia and the Pacific is a big issue for women living with HIV, and one that now we're starting to address at all levels of the response. And as recently as March this year, we know of women being forced to be sterilised in South Africa. This is a practice that is a human rights abuse against all women living with HIV across the world, and one that we need to give visibility to and have dialogue about. And I'd just like to hand over to my colleague Daisy, who would like to speak to that a little bit.
Thank you. Thanks, Rebecca. This, as I already said, that we are working in very interior villages and, as an NGO, and our target area, women, those who are not having any understanding, and their living style is also not that much rich condition. And coming to this, India, culturally, we are bounded, and in depth, interior places and all, women, they couldn't able to raise their voices in the family. They are not having right to do their abortion, and they are not having go for their sterilization. And mother-in-law sister-in-laws they are not that much comfortably. There is dual side. One side, people, women living with HIV, they want to give birth child, but on some other mothers, when we are seeing that in our support group meetings, and they are telling that they want to go for sterilization. But both sides, they are not getting support, first of all, from their family. And also second issue is that information is not properly reaching to the people. And when they are going to the hospital also, as because of the system of decentralization, there is not possible of, they have to go to the head hospital. In that PNC center, that level, they are not getting that much information, facilities also. So there is information, counseling, and surrounding situations. They couldn't able to go for their means go to for childbirth or for the sterilization and for abortion. It's our right. And but in urban side, there is policies and people are doing advocacy. And so as because of our Asia Pacific tool, we are providing this training and empowering the women. Empowering the women is the main to understand about those things and go to the hospitals, and they have to fight for their rights, and they, in their domestic problems, they have to face. This is what we are doing, and training them and getting their best practices. Thank you.
Thank you, Daisy. I think we might allow a few minutes if there's any questions from anybody to our panellists. We actually had 2 more panellists we were expecting here to speak today who've been called away to do other important business as well. So has anybody got any questions they'd like to ask the women?
Oops. Hi. My name's Laura Owen. I'm here from the Victorian Women's Trust here in Melbourne, and we'd like to express our support for all the issues that being dealt with here. I'm currently doing research into the influence of attitudes to menstruation and menopause on women all over the world. And one of the things that I'm having great difficulty finding anything out about is attitudes to women with HIV, living with HIV, and their experiences of menstruation and menopause. So I was very interested to hear your story about going through perimenopause. Have any of you come across any direct problems to do with menstrual blood, any inference that your menstrual blood might infect somebody, or any other experience like that?
I just want to tell you, I'm working in a corporate setup of office. There is 250 corporate staff like that we are working. And working, I am the only woman, positive woman, working in. That is, you know about how the corporate setups. Each month when I'm getting menopause, this because of the bleeding, I'll be getting heavy bleeding and I'll be continuously bleeding for 7-8 days. Our setup of the hospital office infrastructure is very high-fi, and I couldn't able to sit and access my mails and do work. And I couldn't able to go for the toilets also. So in turn, I couldn't able to share this to my friends also, because all are negative. Though so many informations, so many awareness is there, but women living with HIV, certain things we have to keep inside. That fear and self-stigma, and it is because of the society, it's because of the structure. And I couldn't able to share about that. I will take 4 or 5 days leave, CL. I will finish my leave because I couldn't able to go and access my toilet. Every half an hour if I'm going, and you know about the setup of corporate setup of the cleanliness, and bleeding is more, and this I just want to openly telling about this. So information, avoiding the fear and providing the support is not only urban women, and it should be in rural women also. Thank you.
Yeah, and I guess just from an Australian context, I mean, the service that I certainly work in, we have women coming to us with stories about trying to discuss menopause and perhaps, you know, the impact that HIV has on menopause with their GPs, and their GPs don't have any information. And women go online and it's very difficult to find any information. So what women say to us is, we need information. We need to know what's going to be different for us, considering we are living with HIV. What can we expect from menopause? And there's no information. Unless women are connected to an S100 prescriber, which in Australia is a specialist HIV physician who may or may not have information about menopause and HIV, it's hit and miss. And I think one of the things we're trying to create is specific information for women that can be with all GPs, so that at least they can start the conversation about it. But you know, in my country, we're supporting women to move to GP care, so care closer to where they live or where's convenient for them, but that's not necessarily where they will get the most information about things as they're ageing around menopause and HIV. So yeah, it's a challenge. Yeah.
Thank you, Rebecca. Yeah, I just wanted to share about my story also with menopause. I do access private medical rather than public, but there are also challenges there, because I tested for HPV I think 3 times, and then my doctor said, Jennifer, maybe you need to go for hysterectomy because of A, B, C, D. He explained very well. But now to find a gyna to do the operation, I had to wait for more than a year, because most of the female gynas, they were saying they don't do positive women. And he only managed to find a male gyna who said, I'm taking a risk, but I'm going to do it for her. So we need to look at both areas, private and public, because there are also discrimination in the private, and we pay a lot of money. Yeah? Namibia. Yeah. But what we did in Namibia also now for our women, because I work with women right at grassroots level. So I was talking about pap smear to about 27 women. They didn't know what pap smear is. And I said, okay, I'm going to organize with the Cancer Association of Namibia to see whether they can do examinations to you and they take pap smears. So I did. 25 out of the 27 had HPV. One, she had already cancer of the cervix and she didn't know. And one was free. So what we did is that we approached the Minister of Health to say that I think pap smears should be done at public clinics. And the Minister of Health said that we don't have the resources for training our nurses to do that. So what we did is we went again to Namibia Cancer Association to say, please, how can we work together with the Minister of Health so that we can provide this training to the nurses at clinics? So this happened. So in all our clinics, there is a screening of the cancers of the cervix. But still, we have challenges because the nurses have been trained. Our women are reporting back that they go for the screening. They are told the nurse is not here. Come tomorrow. And these women are walking long distances. And some, they go, they have a screening, and then they have to wait and wait and wait. They don't get any response. Instead of the nurses at the clinic to tell them that if we don't respond, then it means that everything is okay, like what happens at the Cancer Association of Namibia, which is private. They inform you that if we don't come back to you, then it means everything is okay. We only come back to you when we see that there's a problem. So most of the women, they just say, oh, they didn't come back to us. So what does it mean? Are we okay or not? I think they should do that. But the challenge is that even though the services are there at the public health centers, it's not working properly. We really need to make sure that there is, if the government says there is services now, make sure that nurses are there. Because women walk and it's only given once a week. They walk distances and then only to be told that the nurse is not there. Thank you.
Thank you. I think, that's absolutely a valid story that you're telling us about the lived experience of women in Namibia, but it's not just Namibia. This is a story that's common, that we hear from many countries in many regions. So even if women know the questions to ask, they know what their rights are, they know how to claim them, they know where to go to access services. The services may be so dysfunctional that they're actually not able to access those services appropriately to get the treatment they need. So when we talk about sexual and reproductive health rights, it cuts across everything, really. It cuts across access, it cuts across stigma, it cuts across discrimination, it cuts across human rights violations. We've got a lot of work to do to get it right, but we have some amazing women here this week who are taking amazing steps to give visibility to the issues, and not just give visibility, to actually create change that's meaningful for us in our lives, and talk to policymakers about how to involve women in the response to HIV that's not just lip service. I think one of the biggest hurdles we have in our region is we can't claim our rights because often we don't know what they are. We have lack of information, and this is great. I mean, this is the start of a dialogue, but then this conference closes, and what happens to our leaders and how they create that communication pathway back in our regions is also a discussion we need to have with our leaders that are here at the conference. So thank you to our panellists. We're actually getting the wrap up here. We can't take any more questions, but the women will be here in the zone to have some informal discussions with you if you'd like to ask them some more questions. So thank you, ladies. Can you reach?